Hello, I'm Charles Vega, Health Sciences Clinical Professor of Family Medicine at the University of California Irvine School of Medicine in Irvine, California. Welcome to this program titled Rediscovering the Clinical Benefits of Aspirin, Arriving at New Conclusions. Joining me today is Dr. Roxana Moran. She is a professor of medicine and director of interventional cardiovascular research and clinical trials at the Icahn School of Medicine at Mount Sinai in New York, New York. Welcome, Roxana.
Thank you for having me, Charles.
This is a quick fire program, and it's really designed to cover a lot of ground in a short amount of time. So we actually have a countdown timer, and we are really going to try to limit ourselves to just 90 seconds for answering some of these critical issues, particularly regarding the use of antiplatelet therapy and aspirin in particular. We'll be talking about recent trials that have compared the relative benefit of aspirin to its risks, and then talk about aspirin, both primary and secondary prevention. So there have been some really important trials going on in the past several years regarding aspirin's primary prevention. Roxana, do you want to briefly describe the ARRIVE, ASPREE, and ASCEND trials? Because this is really important information that every healthcare provider should know.
Thank you, Charles. 2019 was not a good year for aspirin. These three trials you just mentioned showed very small benefit in reducing cardiovascular risk. And actually, there was an increased risk of bleeding. These three studies looked at the value of aspirin in primary prevention of for cardiovascular events, but we have to remember and differentiate between primary and secondary prevention. ASCEND used aspirin to show if there was an effect in serious adverse events in patients who had diabetes but no previous CVD. What they showed is that large benefit that was seen in ASCEND was totally counterbalanced by the bleeding hazard. In ARRIVE, this was designed to assess the role of aspirin in primary prevention of cardiovascular disease in patients with cardiovascular risk. No significant difference between aspirin and placebo for those important vascular events. And the rate was actually much, much lower than expected. In ASPREE, this was another study, was really in the older patient populations. There was a non-significant reduction of risk of cardiovascular disease and cardiovascular related mortality, but the overall mortality was actually higher, and it was driven by cancer mortality.
Right, and so those trials were really, I think, a surprise to me, particularly that last one, because the risk of cancer associated with aspirin versus placebo therapy really came out of nowhere. But to their credit, the American College of Cardiology and American Heart Association have changed their guidelines, have taken these new studies into account, and so really it's a much more limited cohort of individuals who should be considered for primary prevention with aspirin these days. We're talking about individuals between 40 and 70 years of age who have an elevated cardiovascular risk, but also have a lower risk of bleeding. If they have an elevated risk of bleeding, they should not be taking aspirin as primary prevention. In my practice, I see aspirin being continued as primary prevention just because it's kind of continued year to year. And so I see 90-year-olds on it for primary prevention. And so I stop it in those individuals. The recommendations say over 70, don't take it. The other group I'm really targeting are I see some super healthy individuals. They're always on the latest diet, exercise trends. They're taking 20 different supplements, none of which necessarily work, but they're also taking aspirin a day, and they're 26 years old. I'm not sure if they're really deriving much benefit from aspirin at that point either, and so I'm discouraging aspirin use among those individuals as well. So we have, some cases to get to, but on your end, what are you seeing in a cardiology practice regarding some of the clinical issues with aspirin?
So as you know, I'm an interventional cardiologist, and aspirin and P2Y12 inhibition are the cornerstone after PCI. But what we're seeing, and the trials that we've done now, and the current trials are actually showing that you can go to a P2Y12 monotherapy in a large majority of the patients. The reason for this is that there is a lot of treatment failure with aspirin resistance, as well as the preparation, the enteric-coated formulations, for example, the fact that there are other important drug interactions like non-steroidal anti-inflammatory drugs, the fact that aspirin is really also working on the COX-1 related pathways. And we're seeing this very important gastric toxicity and increased bleeding risk with aspirin. Now, I'm not here to say you should stop aspirin in everyone. What I'm here to say is that we really should be really thinking about the use of aspirin in a curtailed fashion in the right patient population who would gain the most benefit from it and the least hazard of bleeding.
Yeah, absolutely. And so we have some cases that that illustrate some of the potential outcomes and how we clinically might apply information from those three trials. So do you want to start with case
Yeah.
one?
So this is a good case. I think the implication for clinical care is going to be really important in which patient actually benefits, as I said. So you're seeing a 63-year-old woman whose only chronic health problem is mild hypertension, currently under good control with lisinopril. The other medications include calcium, vitamin D, aspirin, 81 milligrams daily. She's never smoked and has 2 alcoholic beverages per week. She's had a lipid panel performed a month ago. Her calculated 10-year cardiovascular risk is 21%. So she wants to continue aspirin because my heart is the most important organ, right? So what do you tell her?
Well, Roxanne, of course, you think the heart is the most important organ, and so you'd
I
be
do.
agreeing with her. But that doesn't necessarily mean that aspirin's the right choice for this patient. And this definitely makes me think of the ARRIVE trial. So average age, mid-60s, average cardiovascular risk, between 20% and 30%, all primary prevention. This is not a secondary prevention trial. And I'm looking at this woman, overall her case suggests that she seems relatively healthy. Hypertension is very common, but it's under control. Her lipid panel must be fairly atrocious because her cardiovascular risk in the next 10 years is 21%. And I also, think back to the ARRIVE trial. You were absolutely right. No real difference in terms of major adverse cardiovascular events with aspirin versus placebo, but about a 2-fold increased risk of GI bleeding associated with aspirin versus placebo. So aspirin, I would talk to this patient, use shared decision making, is probably not the best choice for her. What could be a much better choice for her would be a statin, perhaps even a high intensity statin, because of that 10-year cardiovascular risk. That's where I might focus my emphasis on therapy and cardiovascular prevention for her, and see if she's amenable to that using shared decision making. And usually I find I can make that argument pretty convincingly, because statins in the long run not associated with a ton of severe adverse events. Let's switch gears. I'm going to give you a case now. We'll kind of ping this back and forth like a tennis match. You're seeing a 60-year-old man for routine follow-up. He was diagnosed with type 2 diabetes 7 years ago. His last hemoglobin A1C a week ago, 9.2%. Other chronic medical conditions include obesity and hyperlipidemia, but he has no history of cardiovascular disease. His medications in my clinic are pretty standard regimen: glipizide 5 milligrams twice daily, metformin 1,000 milligrams twice daily. He is taking atorvastatin 40 milligrams daily. Now, his mother and his wife use aspirin to prevent heart attacks. So there's a peer pressure involved here, and he wants to know if he should as well. So what do you tell him?
So take a look at this patient. This is a perfect patient, the kind of patient we see all the time. The focus so much on the heart, but if the focus is on the heart, the real target should be his hemoglobin A1C, which is extremely high at 9.2%. We're seeing a lot of uncontrolled diabetes out there, and control of the glycemic control, and especially now with the SGLT2 inhibitors, is really where this patient should be going. In the ASCEND trial, where we were looking at the patients with diabetes, this particular patient, if he would be taking just aspirin, the only thing he would gain is an increase in bleeding. There was a little bit of a reduction in the primary vascular events, but that was completely counterbalanced with GI bleeding. This patient should be focused on reducing hemoglobin A1C.
Yeah, I agree. I think the thing with ASCEND, it's almost like you're trading one for the other. Would you rather have a risk of mostly GI bleeding, although there were some cases of intracranial bleeding, which is a much more severe outcome, which we want to avoid for everybody. Still pretty rare with just routine aspirin therapy, versus having a myocardial infarction, a stroke, or revascularization. And it almost comes down to what's the value of the patient. Do you value one more than the other? And I think that a lot of patients, when they hear, there is this potential GI bleeding or any bleeding side effect, it's just off the table. It's really hard to kind of bring them back into the conversation and say, but there is some cardiovascular benefit associated at least with diabetes per the ASCEND trial.
I think, Charles, you make the perfect point. This is, again, a shared decision making. Taking a look at this patient's cardiovascular risk, it's high. Prevention of those events are important, but his diabetes should be central. It's his #1 priority in reducing and controlling those risk factors. In fact, the SGLT2 inhibitors actually reduced cardiovascular events. And there probably will be a future for aspirin for this patient, but we just want to make sure that we take care of all of those important first line treatment for diabetes as well.
Yeah, GLP-1 receptor agonist and SGLT2 inhibitor.
Exactly.
Use those, get rid of the glyphoside, overall much healthier. Not always easy to do with low-income populations, but even in my clinic, the biggest safety net clinic in Orange County, I'm having more and more success with it. So it is possible. Let's do it.
Diet and exercise plan, always a good one. So Charles, let me go to the third case. You're seeing a 75-year-old woman and history of hypertension, osteoarthritis of the knee, along with chronic low back pain. The medications include amlodipine, 5 milligrams, levostatin, 20, and aspirin, 325 milligrams. She uses at least 6 tablets of aspirin daily for analgesia.
Yeah.
She notes there's some epigastric pain alleviated by food over the past several weeks. No change in the stool. Her weight is stable. You suggest to change her aspirin regimen. What do you mean? She says, isn't aspirin good for you? What do you tell her?
This is a conundrum that I see because while certainly most patients are using aspirin for cardioprotection, there's still a cohort of individuals out there who are using it more for its analgesic effect. It's not the most convenient analgesic to use, but because it does require frequent dosing compared with something, say, like naproxen. But she needs something for her pain, I presume, as well as we have to consider the cardioprotection aspect of it. So with the ESPRIT trial, we know that the patients did not do better in any of the major outcomes that when they compared aspirin versus placebo, and those were very patient-centered ones. This is death, long-term disability, dementia, didn't improve any of those outcomes, but there was an increased risk of bleeding, again, associated with aspirin versus placebo. So aspirin is not a great choice for this patient. I do have to think about what we're going to give her for osteoarthritis. Acetaminophen would be my go-to because it doesn't have that GI bleeding risk. And then if we're going to use an NSAID, what about a topical NSAID that doesn't have those systemic side effects? So that's where I would recommend that she go with this case. And we'll try to guide her off that 6 times a day aspirin therapy. All right, let's flip our attention now to secondary prevention, which is definitely, I think, more of the world you live in, I bet, day to day. In patients with atherosclerotic cardiovascular disease, aspirin still reduces cardiovascular morbidity and mortality. Is that right?
Absolutely, and I think it's really important that we don't walk away from that thinking, well, if you have established cardiovascular disease, you should stop aspirin because all these other trials were negative and you're going to have higher bleeding rate. And I think there's no question that we have large body of evidence in secondary prevention for patients with aspirin therapy. Where the plot thickens, I think, and when we are starting to have a little bit more of an evaluation of what we should be doing is when you start to have combination therapies with P2Y12 inhibitors in patients with cardiovascular disease. And we know that in acute coronary syndrome for patients based on the CURE trial, that the use of dual antiplatelet therapies for 1 year with aspirin clopidogrel was superior to aspirin alone. So we're starting to see the stacking of these therapies with P2Y12 inhibitors. What's happening though, after a PCI at a certain number of months, whether it's for stable coronary disease, 3 to 6 months, for ACS, 12 months afterwards, what we're doing generally is we're dropping the P2Y12 inhibitor and continuing patients on lifelong aspirin. And the question is, can we reverse that? Can we think about other pathways, and can we go just with the monotherapy of P2Y12 inhibitors? And it's a lot about the bleeding parameters that I discussed earlier, and some of the limitations of the use of aspirin alone and for protection in these patients. So there's been a lot of data now on different trials, and we have to choose as we go along.
Well, I think of dual antiplatelet therapy, and to some extent, in my world, P2Y12 inhibitors more as kind of being the sprint versus aspirin being in the marathon. Patients may be surviving after a cardiovascular event, 20, 25 years, and aspirin seems to be what carries them over. But is that thinking changing? Is it more that now we should be thinking about using P2Y12 inhibitors, for example, over the long run for these patients?
So that's a really good question. It's a little bit tricky, right, Charles?
It
Because
is.
we know that in clopidogrel, with clopidogrel patients who are treated with clopidogrel, and just recently, the Taylor PCI was presented with 35% of the patients are carrying the CYP2C19 allele, where they wouldn't be responsive to that
Right.
P2Y12 inhibitor. So you can't just say right off the bat, I can just give you clopidogrel for life. What we did in the Twilight study is we withdrew aspirin after 3 months in that sprint, as you're talking about, with and there we went to a double-blind placebo-controlled fashion, withdrawing aspirin, and we showed a 50%, close to 50% reduction in bleeds, a clinically significant bleeds without any increase in the ischemic outcomes. What we did find is that here now, especially in the acute coronary syndrome patients and diabetic patients, in those patients who have complex disease, all of this has been published, where we are seeing you're able to actually get that patient through longer treatment with a potent agent for a longer period of time,
Right.
without having the bleeding events. So that's where I think it's an innovative, a new way of thinking about this going forward.
Absolutely. So yeah, more to come, but let's summarize where our conversation, where we stand today. So in individuals with a high cardiovascular risk, but without cardiovascular disease, these are primary prevention patients. And we know that aspirin can have some cardioprotective events or effects rather, but particularly in individuals with diabetes. But looking at the ESPRIT trial, looking at ARRIVE trial, not so much with just elevated cardiovascular risk alone. We do know that aspirin as primary prevention does promote a higher risk of bleeding, particularly GI bleeding. And so aspirin really should not be used in those who are over 70 years of age and in individuals with a high bleeding risk, particularly if they have a history of bleeding, major bleeding in the first place. That to me is the automatic, let's stop this sign. But in patients who already have atherosclerotic cardiovascular disease, antiplatelet therapy with aspirin is still part of that regimen. In some cases, dual antiplatelet therapy may be warranted with a P2Y12 inhibitor. And so therefore, it does come down, as we say, to shared decision making once again, and just working with patients to understand those values. And I like those cases because they show that aspirin is something a lot of patients really hold on to, and I think it's something they understand better than their other drugs because aspirin's been around so long, and their grandmother took it, and their mother took it, and now I'm taking it. So I think that it's something that's worth a discussion because it does have its benefits. Those benefits are also offset by some potential risks.
So,
Roxana,
Charles,
yeah, go ahead.
So, Charles, you make a really, really good point. And what in your summary, what you're actually telling our clinicians out there is that one size does not fit all. We really have to have this conversation with our patients, going over their risk, benefits, trying to explain to them their other cardiovascular risk, and then put aspirin into the context of who they are specifically for that individual patient and use shared decision making. That is really the biggest takeaway that you're bringing to us today.
All right. Well, thank you very much for being with me today. And thank you and our audience as well for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation. Stay safe, be well, and keep healing people. Take care.